Hello, my name is John Devlin. Practice guidelines for the care of the critically ill can be challenging to adopt into clinical practice. In today's web conference, I'm going to focus on overcoming barriers when implementing the 2013 Society of Critical Care Medicine Pain, Agitation, and Delirium Guidelines. Most patients who are admitted to the ICU experience pain, anxiety, fearfulness. Often they have altered sleep. Sometimes they'll develop delirium, and frequently after ICU discharge, they'll experience post-ICU functionality concerns as well as post-traumatic stress disorder. After 4 years of development, a multidisciplinary group of experts in the field of ICU pain, sedation, and delirium published in January of this year clinical practice guidelines for the management of pain, agitation, and delirium in adult patients in the intensive care unit. These guidelines present 55 different statements and recommendations, which I think is the most that have ever been tried to be included in one practice guideline in the ICU field. One of the potential challenges when adapting the new guidelines into practice is that only 12 of the 26, or 23% of the recommendations that could be voted on by our guideline group are at a level 1 or strong level, which could potentially lead to stress amongst clinicians when guideline recommendations are not strong. The large number of different practice guidelines that are available to manage patients in the intensive care unit can be a barrier to the implementation of any new guideline. Leon and colleagues evaluated 625 French patients and found that the compliance with any one guideline when they looked at a whole host of different guidelines was generally quite poor. For example, when they looked at the compliance with analgesia and sedation monitoring, it was only around 24%. In the next slide, you can see that compliance was good when institutions only looked at 1 or 2 guidelines. However, as you moved across to look at compliance for a full 13 different practice guidelines that were available and could be used in the unit, compliance rapidly dropped. The perspective of the caregivers involved in the management of pain, sedation, and delirium in the ICU is also important to consider. For example, physicians and nurses might have a very different approach to managing pain, agitation, delirium in their patients. Then one might add in the family, who spend an increasing amount of time at the bedside and in whom pain, agitation, delirium really resonates on a continuous basis. And then you could bring in the ICU director, who manages these clinicians, the hospital administrator, who may have a very different approach than the bedside clinicians, and of course the payer like CMS or Medicaid, who may have a very different perspective in terms of the priorities related to pain, agitation, and delirium management in the ICU. Before adapting new pain, agitation, and delirium guidelines into practice, it's important that ICU clinicians evaluate what current practices are. In the area of pain assessment and management, one question to consider would be, how well do we assess and manage pain in our patients, particularly those who are nonverbal? In the area of sedation assessment, some of the questions that should be asked include, how frequently are patients maintained in a light and arousable state? Are most patients who require continuous sedation managed with daily awakening or tight protocolization? Does excessive sedation routinely prevent the completion of spontaneous breathing trials? And how many patients are managed with restraints? When looking at sedation choice, it's important for clinicians to evaluate what proportion of intubated patients are managed with continuous sedation, which of course would include differentiating use of midazolam from propofol and dexmedetomidine, and also whether an analgesia first approach has been tried or considered. Does delirium screening occur? Has the CAM-ICU or intensive care delirium screening checklist been implemented? How frequently does delirium screening occur? Is it completed each patient, each shift? Is it documented? And is it discussed between ICU caregivers during bedside rounds? Regarding delirium treatment, How are patients with delirium managed? Are risk reduction strategies routinely implemented and used? How are antipsychotic agents used? And is dexmedetomidine used in the patients that have delirium? And lastly, early mobilization. How much physiotherapy activity currently exists in one's ICU? And has early mobilization been discussed or tried? What have been the successes? In the area of pain, agitation, and delirium, the perception among clinicians of what actually happens can be quite different than what actually is occurring. In one large survey of 85 ICUs around the country that incorporated a 24-hour practice snapshot, clinicians perceived, for example, that sedation interruption was occurring in 66% of the ICUs, but in actuality it was being performed in only 36% of patients. Clinicians perceived that delirium monitoring was occurring in 25% of the ICUs, but in actuality it was being performed in only 10% of patients. So what are the steps when adapting the 2013 pain, agitation, and delirium guidelines? Well, let's start simple. I think one of the most important things is focus on strategies to make sure that pain, sedation, and delirium assessments are being made. This is really foundational. So we want to make sure these assessments are being conducted regularly, that they're being conducted reliably, and that they're being documented. Let's start with pain assessment. Well, I think the first most important thing with pain assessment is whether the patient is verbal or nonverbal. If they're verbal, well then of course it's fine just using a numeric rating scale and ask the patient out of 10 if they're in pain. However, if the patient is nonverbal, increasing evidence has demonstrated that numeric rating scales do not accurately evaluate pain. In these instances, a behavioral pain scale or the clinical pain observation tool should be used, and there's a strong recommendation to support each of these practices in the guidelines. With sedation assessment, it's extremely important to avoid deep sedation in most patients when this is not the goal of therapy. We certainly know there's sedatives often can lead to an unarousable or comatose state if they're not accurately titrated, and certainly this is a great risk factor for delirium. More recent data suggests that even short periods of early deep sedation can be associated with both a longer duration of mechanical ventilation and reduced 6-month survival. One of the most important recommendations in the new PAD guidelines is that when sedative medications are used in the critically ill, they should be titrated to maintain a light rather than deep level of sedation in adult ICU patients, unless clinically contraindicated. The 2013 PAD guidelines strongly advocate that a validated sedation assessment tool such as the Richmond Agitation Sedation Score or the Sedation Assessment Score be routinely used in practice. In addition to maintaining patients at a light and arousable level of sedation, this also helps support delirium screening, early mobilization, as well as being able to implement spontaneous breathing trial. Another strong recommendation that is made in the 2013 Pain, Agitation, and Delirium Guidelines is that patients should be managed either with daily sedation interruption or a light target level of sedation be routinely used in mechanically ventilated ICU patients. There are many potential barriers that are associated with the use of daily sedation interruption in the ICU. One of the most important strategies to overcome these barriers that are listed here is really to have a discussion and engage the bedside nurse. It's also important to consider the results of a recent study that was published in November 2012 in JAMA that compared hourly sedation protocolization with or without daily interruption. And in this study, in which all patients were managed with continuous benzodiazepine therapy, there was no difference in duration of mechanical ventilation between the hourly protocol with or without daily interruption. So this study certainly does not suggest that there's no role for daily interruption, but it does suggest that if clinicians are willing to adapt tight protocolization, and again in this study, Just to emphasize, it was hourly sedation assessment and titration of benzodiazepine therapy that outcomes may be the same between patients managed with either strategy. Interestingly enough, in the study, nurses actually were more supportive and more willing to do hourly sedation assessment than they were the daily interruption component. Let's spend just a minute talking about delirium screening. There's a number of important strategies that clinicians should consider when trying to boost delirium recognition efforts in their own ICU. As already mentioned, sedation assessment should be occurring regularly and reliably. It's extremely important to have buy-in from nurse and physician managers. Education that is delivered both regularly and also at both in a classroom or on the web, as well as at the bedside, should be completed. I think it's important that clinicians should be comfortable with not being able to evaluate components of delirium at certain times in certain patients. It's important that these scores are documented in the patient record. It's also important that there's a mandatory discussion of delirium evaluation during patient rounds. This is where you're really going to have the opportunity to look at risk reduction and consider all the various factors that could be accounting for the patient's delirium. One of the most important recommendations in the PAD guidelines is that early mobilization should occur whenever feasible. In this picture here, you can see a respiratory therapist holding the vent tubing and a physiotherapist helping the patient walk. There's a number of very useful early mobilization protocols that have been published. For example, this one from the University of Chicago. There's a number of different resources available on how to adapt early mobilization strategies in ICU practice, including the AHRQ, as well as various other sites that have implemented quality improvement areas in this area. I think one of the most important things to do is to consider having one of your PAD champions or clinicians in your unit spend a day at a nearby institution that has successfully implemented an early mobilization protocol. In a patient that's suspected to have delirium, a stop and think approach should be used. Questions to consider including, is there a med that needs to be stopped or the dose lowered that could be causing delirium? This can include sedatives. Is the patient on the minimal amount of necessary sedation and analgesia to maintain patient comfort, or does the choice of the sedative need to be changed? It's also important to think of the classic things that can be causing delirium in the ICU, such as toxic situations, hypoxemia, new infection or sepsis, immobilization. There's a number of non-pharmacologic interventions like giving their patients hearing aids and glasses, and then electrolyte replacement. Clinicians should also consider adopting a delirium protocol in their intensive care unit, such as this one from the Vanderbilt group that's available at www.icudelirium.org. One thing that's important to note in this delirium protocol is the low priority by which the protocol advocates the use of antipsychotic therapy. Generally, it should only be used in patients that have agitation that cannot be managed with other strategies. So when we look at a quality improvement or quality assurance program for changing the ICU culture in the area of pain, agitation, and delirium, it's important, as I've previously mentioned, to evaluate current PAD practices, summarize the evidence from the guidelines in a way that can be adapted into your unit, identify some of the local barriers to implementation, measure performance over a period of time, and ensure that all patients are receiving the interventions. I think the interdisciplinary team plays a key role in implementing any new recommendations or efforts surrounding pain, agitation, and delirium. This interdisciplinary team, of course, can be made up with physicians, nurses, respiratory therapists, pharmacists, physical therapists. The hospital administrator is key. Family can play a very important role, and of course the patient. When considering implementing ICU sedation protocols and guidelines in this area, phase one is really a development phase where you really want to identify who are going to be the physical champions that are going to really help lead change. Make sure that you have a committee that is multidisciplinary, synthesize available data, and draft a protocol. Phase 2 really is the implementation phase. This is where you might do a pilot analysis of one ICU or a small number of beds in an ICU, looking at efficacy, safety, and adherence. It's important to have endorsement of this protocol from institutional bodies or committees within your institution. Education should be provided to all ICU clinicians. And again, this education in many cases should be applied at the bedside and also needs to be continuously provided to new ICU clinicians, including physician house staff as they come into the unit. And of course, any of these guidelines are going to work a lot better if they're integrated with electronic documentation and clinical monitoring systems. The last stage of any implementation practice is continuous quality improvement. So it's important to periodically measure the various metrics associated with these guidelines. As new literature becomes available, update the guidelines. It's important to publish and present efficacy, safety, and compliance data, which could include benchmarking against other institutions or seeking guidance from other institutions in further guideline development. It's also important to consider that pain, agitation, and delirium management is very, very much integrated, and that sedation assessment, pain assessment, and delirium prevention and treatment all work together to help support spontaneous awakening trials, early mobilization, and maintaining patient comfort throughout the ICU stay and improving post-ICU functionality. One strategy to integrate pain, agitation, and delirium management is an ABCDE protocol, which includes an awaken and breathing trial coordination, daily consideration of sedative and analgesia of choice, routine delirium screening, and early mobility exercise. Lastly, as you move to improve practice in the pain, agitation, and delirium area in your ICU, it's always important to remember that there is going to be the rare patient where some components of the PAD guidelines do not apply. And so it's important to remember that these are only guidelines and that an individualized approach should always be used in your patients. So some of the key messages when as you strive to implement the 2013 FCCM PAD guidelines is consider the perspective of different ICU team members. An interdisciplinary team is crucial for success. Regularly and reliably evaluate pain, sedation, and delirium. This is really the foundation for change. A light level of sedation should be targeted. Carefully evaluate your current practice. Be realistic about what the barriers are and sort of what the history of your ICU is in making change in this area. Identify potential barriers to change prior to implementation, and consider using a bundle like the ABCDE bundle to provide a framework for improved ICU care and outcome in this area. Thank you.